Hello, everyone. This is Sapien from Nanjing First Hospital on .com. It's my honor to be as a moderator on behalf of Professor Sao Chen. The operator of the lab case is Professor Junjie Zhang, Vice President of Nanjing First Hospital. Please introduce your team and your case.
Thank you, Dr. Gao, for your moderate and the introduction. So let me introduce my team. Sincerely, on behalf of Professor Sao Chen, our team. On my right side is Dr. Kong Xiangquan and Dr. Zhu Jiancheng. And also today's echocardiography is Dr. Zhang Juan. So today's live case is aortic stenosis case. We were treated this case with a TAVI procedure. So first, let me introduce clinical information of the patient. So please show the slides. Next slides. So this is a 76-year-old gentleman presented with exertional dyspnea for 1 month. This patient has essential hypertension and TIA. So after admitted, you can see the BNP is a little elevated with a normal renal function, and also ECG show is normal. ASIC score after calculated was 4%. It's a moderate. So clinical diagnosis for this patient after echocardiography, it's a typical severe aortic stenosis. Next. Let me show you the echocardiography of the baseline situation. So you can see it's a 4-chamber view, severe aortic stenosis, and also with a moderate aortic regurgitation. So the maximum velocity of aortic valve is 5.1 meter per second. The mean gradient is nearly 60 millimeter mercury. So it's a typical severe aortic stenosis. And also you can see PHT is 318. So it's also accompanied with a moderate aortic regurgitation. And also you can see the LV function is normal. EF was 68% with a dilated LV chamber. LV IDD is 55 millimeter, and also with minor pulmonary artery hypertension, 42 millimercury. So next. So before decision, we also do the CT analysis for this patient. You can see from the CT analysis, it's a typical type 1 bicuspid aortic valve with left and the right cuspid fusion. You can also notice the leaflet of the non-coronary cusp. There is a calcification, but the volume is only 168. So it's a minor calcification. And also the most important parameter of the CT analysis is the annular area is 377. So accordingly, I think decision made to select the 23 millimeter for Sapien 3 valve. And also LVOT 4 millimeter below the annulus, the area was 361. There is no severe, there is not so much calcified. Next. Next slide, please. So in terms of a coronary obstruction risk, you can see the left coronary high is 40 millimeter, right coronary high is 60 millimeter. It's high enough, and also the sinus is also large than, bigger than 27. In terms of the STG, mean diameter is 25 and the high is 18. Not so big. Next. So we use a circle method. So after method, decision made to select 26 millimeter Sapien 3 valve for this particular case. Considering there is no severe calcified lesion, so we try to direct without a balloon angioplasty, so direct standing for this patient. Next. But another problem is for this patient is peripheral artery disease. You can see both left and the right iliac and femoral arteries, there were severe lesions. The minimal lumen area of the right iliac artery only 2.7 millimeter. Left side is also 3.2. So for this patient, actually is although there is severe narrowing, but not so calcified. So our after hard team discussion, we still prefer from the femoral approach, but we should do the balloon angioplasty before we insert the E sheath. So next. So finally, for this particular case, our procedure strategy is general anesthesia with TE guidance. We will select the right femoral approach. Of course, before we inserting the E sheath, we will do the angioplasty for the right iliac artery disease. Then insert the sheath, then do the TAVI procedure with a 23 millimeter Sapien 3 for this particular case. So actually, we have performed the peripheral artery angioplasty for the right iliac artery. Let me show you what we have done now. So firstly, we puncture with a macro puncture from the right femoral. Next, then we insert the ProGlide, two ProGlide suture device. Then do the aortic angiogram. You can see both the left and the right iliac artery there were severe narrowing. Then also you can notice the right iliac inner artery were totally occluded with the collateral supply from the abdominal aortic artery. Next. So you, from the DSA, we can see there is multiple lesions at the right iliac and the femoral artery. Next. So decision was made to perform angioplasty for the right iliac artery disease with a 6 millimeter peripheral balloon. You can see it's a longer balloon. Diameter is 6 millimeter. Long time inflation, maintain 3 minutes. The balloon, the shape of the balloon dilation, you can see it's a totally expansion. So it's not so calcified. So long time inflation reduce the risk of the dissection. Then next, after successfully balloon angioplasty for the right iliac artery, we successfully insert the E sheath 14 French at the E sheath. You can see there is no resistance. So this is what we have done now.
Thank you, Professor Zhang. Thank you for introduction. This is very characterized with very challenging peripheral artery access. Professor Zhang, please introduce your baseline TE information.
So can you put the echo on the big screen?
Okay. Actually, from the TE, this is a short axis view of the valve. So, a concordance with the TTE and CT, we can see actually is typically a bicuspid aortic valve with right coronary and left coronary fusion, and we can see there is a raphe. There is a quite calcified raphe between them, and the movement of the leaflet is quite reduced, with there is a large volume of calcification in the edge of the leaflets, and the opening direction of the aortic valve is about 1 and 7 o'clock. And this can more clearly using the 3D TEE and confirm that this is a type 1 bicuspid aortic valve with calcified leaflet and calcified raphe. And all this indicated the high risk of perivalvular regurgitation after the valve deployment. And we also calculate the annular area is about 3.5 centimeters square. And the area function is quite preserved. and the LV is mild dilated, and hypertrophic remodeling of the left ventricular, and the MR is mild. But actually, from the long-axis view of the valve, we can also see there is at least moderate or moderate to severe regurgitation, aortic valve regurgitation. Yeah. So we can see the transvalvular gradient is typically high, and we can see the regurgitation CW Doppler diaphragm from the Doppler waveform. Yeah, this is that. That's all for this patient. Yeah. Thank you.
Okay, thank you, Professor Juan. Thank you for introduction with the TE information. And we just the Professor Zhang had crossed the stenotic wall and wire in the left ventricle. Professor Zhang, what's the next step?
So you can see we successfully with a straight wire cross the severe aortic valve into the LV. Then we exchange it with a pigtail. So next, I think we will use a pre-shipped wire as a support wire for facilitate advance the Sapien 3 valve.
Okay, Professor, I know you choose Sapien 3. And do you think what's the advantage of Sapien 3 compared with self-expanding valve?
Yeah, I think it's a totally two different valve, maybe suitable for different scenario for the aortic stenosis. For a balloon expanded valve, I think there is some advantage, like especially for younger patient and a low risk patient. In terms, it's a short frame, so there will be easy coronary access compared with a self-expand valve. This is the first advantage. The second is, I think there is a lower rate of PVL and a lower rate of pacemaker implantation after valve implantation compared with a self-expand valve. But of course, there is still some advantage of self-expand valve, like for severe calcified lesions, especially for annular calcification. So there is a risk of annular injury if we use balloon expansion valve. As this scenario, I prefer use self-expansion valve. But for this case, I think considering the sinus is not so big, so and also the calcify is only mild, so I prefer balloon expand valve for this particular case. Another important scenario for this case is peripheral artery disease for this case, because there is severe narrowing both left and the right iliac artery. So considering to reduce the risk of a peripheral artery complication, so I would like to use, I prefer to use balloon expansion valve because of the small size of the artery sheath, only in terms of E sheath only 14 French, compared with the self-expand valve at least 18 French. There will be associated lower rate of peripheral artery complication.
Thank you. Thank you, Professor Zhang. Thank you for sharing with us with your great experience. And Professor, what's your next step?
Okay, now I think we are all ready. We have set up our railway, so we are ready to insert the valve, Sapien 3 valve. For this, according to the CT analysis and the circular method, so we decided to use a 23 millimeter Sapien 3 valve with a normal fillings. So also, I think the implantation depth, I think with normal 80 to 20 ratios.
Okay, thank you.
面朝上。
Professor, do you perform predilation before implant the valve?
Okay, for this particular case, there is no severe calcification, so I prefer use direct valve implantation without predilation.
Okay.
可以，小心。 看到下面重创，
已经是最小项。
来了吧
OK，
？Okay, now we insert the valve. Okay, right place. 把它打成 AP. Go to more cranial. Okay, make the complaint of the valve. It's good. 这样啊。OK， 拉球了啊。OK， 直接了啊。OK， I pull the whole system. Okay. Lock. Good. 往怀里吹。And we load the balloon into the valve. Good position. Good. Just check. I think it's good. I think we should move back a little. Good. Okay. Now it's ready. We have loaded the balloon into the valve. Okay. Okay, please go to aerial air projection. Hold the wire. Okay, good. Hold the wire. Okay, good. I flex the valve tip. Okay, good. Let's go to the component view. LAO 12 degree. Good. Good position. Okay. Yeah. I think it's good position. Yeah. Let's take a picture. I think it's too high. Yeah. Okay. Okay, 结束啊。OK， 推手柄这个啊。Okay, good. Then we lock. I think the position is good. We can do some. Yeah， 搞一点点是往怀里转。Okay, let's take a picture.
Is 80-20?
Yeah.
Okay.
I think we still need a little high. Okay, let's take a picture again. What do you think? I think it's good. Okay, so we are ready to implantation. 准备好了吗 Okay, pacing. 118. Rapid pacing. 然后我再照影，然后你再准备好啊。Okay. Picture. Okay, ready. Pacing. 打起来。Pacing. Good. Nice. 1, 2, 3, 4, 5. Done. Okay, stop pacing. Good.
Very stable.
Okay.
The hemodynamic is stable. Yeah.
So
Blood pressure is good.
good. Good. 把这个什么，好，可以啊。And take a picture. So after we successfully deploy valve, then we take a picture. Ready? So with the adjusted projection, more caudal, complete view of the valve. Yeah, good. Still a little caudal. Good. Ready?
Very good.
Okay. So Dr. Zhang Juan, can you check the TE?
Okay.
I think it's good.
Yeah, only mild, maybe PVL or regurgitation. Mild.
The position is good.
Yeah.
I don't think there is PVR. It's central.
There's almost no PVR.
Okay.
Yeah, I think
And
so.
the position is good.
This
And
is
the
good.
valve is working well. So
Okay, we can put out.
and we can see the quite round, the circle shape of the valve in the short axis view. Yeah. There's almost there's no PVR.
Okay,
and
good.
the position is good.
直接出了啊。
So the gradient.
Okay. There is no PVR according to the echocardiography. The position is good.
The maximum transvalvular velocity is about 1.3
Okay,
meter
1.3.
per second, and
It's a
the mean pressure gradient is about only 3
okay.
millimercury. Yeah,
Very nice
it's
result.
perfect. Yeah.
Okay.
The situation is good. There's no PVR, and the transvalvular velocity, the mean pressure gradient is all very perfect. Yeah.
Okay, actually you can see from the thermodynamic, actually there is no gradient. So pressure a little high. I think, yeah, we can lower the pressure. Please, my anesthesia colleague, please lower a little pressure for this patient. Finally, I think it's a good result after Sapien 3 implantation for this particular case. And there is no PVR, and the maximum velocity only 1.3 millimeter. The mean gradient only 3 millimeter. It's a perfect result without injury the coronary access. So for this particular case, I think Sapien 3 is quite suitable for, and with excellent result, with excellent hemodynamic parameter. So we have put out the wire and put the pigtail at the left ventricular. Now let me do a final picture, aortic loop picture for this case. There is, I think there is no PVL for this case.
Very great result.
Yeah. Nice result.
Yeah.
So I would like to finish the case. And the next step, I would like to treat to do the angiogram for this patient's right iliac artery. When we move out to the E-sheath to see is there any severe dissection or is there any flow limited dissection. If there severe dissection, there is no flow limited, and also there is a radial stenosis less than 50%, I will just leave it. If there is a flow limit dissection or still there is a severe radial stenosis more than 50, maybe I will put a graft stent for this case, for this right iliac artery disease. So Dr. Kong will do the next step for the iliac artery disease. Go ahead.
Okay. Okay, Professor Zhang, what's for this 76-year-old gentleman, what's your antithrombotic strategy after the TAVI procedure?
I think for this particular case, a single antiplatelet therapy with aspirin is enough, because this patient is a sinus arrhythmia. According to the guideline, I think lifelong antiplatelet therapy with aspirin is our recommendation for this patient.
Okay, thank you. I noticed you did not perform any coronary access protection before TAVI procedure. And what do you think? What's the risk of coronary occlusion about this patient?
For this particular case, I think there is extremely low risk of coronary obstruction for the TAVI procedure. I think the valve, according to the sinus, I think is big enough for the Sapien 23 millimeter valve. Is the first point. Second is the coronary high. Both left and the right coronary high is higher than 15 millimeter. And also the leaflet, actually, both left and the right corner leaflet is not so, there is no big calcium nodule at the leaflet tip. So after valve implantation, I think there is no risk of coronary obstruction. Also, you can see after procedure, we do the coronary aortic root angiogram, the flow, both air left main and the RCA is totally very good. There is no injury.
Yeah, thank you. Thank you for your great experience sharing with us.
Another, I think, important point is pacemaker implantation. Actually, you can see the implantation high is the ratio is 19 to 10. I think a little high for this case. So can we temporarily stopping the temporary pacing for this case? Stopping the temporary pacing, adjust the protector raised to 50.
50.
Let's see. Maybe for this case, we no need the pacing wire protect. You can see, yeah, actually it's good.
Yeah.
The QRS width interval is good. There is no RBBB. There is no 1 degree IV block. So for this case, maybe after procedure, I will pull out the temporary pacing wire protection.
You pull out the temporary pacemaker after procedure immediately or after 24 hours?
No need 24 hours for this particular case. Actually, there is no any sign of the AV block.
Okay.
So actually, after procedure, we can pull out the pacing wire.
Okay, thank you.
What are you doing, Dr. Kong?
Yeah, first I will put another catheter to the left iliac artery. When we pull back the issues, we should do angiography.
Yeah, from the contralateral artery, left iliac artery, Dr. Kong insert another pigtail at the aortic to do the aortic angiogram. Yeah, when we pull out the sheath to do the angiogram from the contralateral side to confirm there is a injury of the right iliac arteries.
We first pull out the pigtail, then we'll put GR catheter to the
So Jadigans right catheter from the left femoral.
Professor Zhang, your team has a great experience at dealing with this very challenging peripheral artery. And my question is, what's your backup strategy if we failed to insert the issues?
Actually, for this particular case, I'm not worried we will fail to insert the issues. Although there is severe narrowing, but actually there is no severe calcification. So we were sure, we will anticipate we will successfully gradually dilation. We will use a 6 millimeter balloon to dilate first. If successfully the balloon is fully dilatable, I think we can successfully insert the French 14 French sheaths. On the another hand, if there is a severe calcification lesions, which means undilatable, for this scenario, we will use a shock wave. Yeah.
Okay.
Similar to coronary artery, severe coronary artery disease, therapy with IVR will facilitate the lesion prepare. After successfully lesion prepare, we still can insert the sheath. Yeah.
Okay.
Of course, after procedure, there is gentle. There, be careful. There is dissection. Be careful. Yeah. Now it's good. Always make the guiding catheter tip coaxial.
Now we'll pull back the issues. About us now.
Yeah.
Meantime, please test. Test.
Oh yeah. I think it's good.
Yeah, looks good. There's some dissection in the iliac artery.
Very good.
Yeah, I think there is no severe dissection. There is flow is good. There is no flow limited dissection. We can take a picture now.
Yeah. Okay.
我看一下，对，哦，OK。
Okay. Ready? Yes, looks good.
I think it's type B dissection. What do you think? Do we need a?
Flow is good and there's no flow limited.
Yeah.
So I think we don't put a stand. I think. Yeah.
I think so. What's your option, Dr. Zhu? Speak English. Okay, there is no need to put a stand. Yeah, it's a type B dissection without flow limited.
Yeah.
I think we can leave it. Yeah. Okay, good.
Okay, now I will pull out the issues.
Okay.
Do
Across the puncture site.
budget.
Okay.
Show you.
So we have put two plug glide at the femoral puncture site.
Okay.
So this is a beautiful of the Sapien 3 TAVI procedures. I think the low profile for the issues only 14 French. So which means with associated lower rate of peripheral artery complication after procedure. Yeah.
Yeah.
Especially for this kind of with cases with severe peripheral artery disease. So use a smaller sheath where lead to resulting lower rate of peripheral artery disease. So this is my favorite. Yeah. So I think we have completed this case. So let's give a summary. This is an elderly gentleman, more than 76 years old, presented with heart failures. Echocardiography show severe aortic stenosis with BAV. It's a typical type 1 BAV. And according to the CT analysis, so decision was made to select the 23 millimeter Sapien 3 valve. Another characteristic for this patient is severe narrowing at the right femoral and the iliac artery. So before we insert the E-sheath, we do the balloon angioplasty with a 6 mm balloon. After successfully lesion prepare, we insert the 40 French E-sheath. Then stepwise, we insert the wire and advance the 23 mm valve. And with a nominal position, we successfully deployed the valve. After deployment, the echocardiography and also the angiogram shows there is no PV error, and the hemodynamic parameter show good result with median gradient only 3 mm mercury. So we successfully remove the sheets, and the angiogram shows there is only a type B dissection without limited anterior flow. So we just decide to leave it with medicine therapy. So this is our case. So ladies and gentlemen, thanks very much for your observation. Sincerely on behalf of Professor Xiaoliang Chen, really appreciate your invitation and participation. Thank you. Okay, that's all. So we have removed sheaths and suture the puncture site. And
Yes.
finally, still we will do the lateral angiogram, confirm there is no any complication of the right iliac artery. Okay, we can do it, angio.
Yes, we have successfully sealed the punch site, so we will do next angio to check the iliac artery and the punch site. Okay. Are you ready? Okay.
非常好。
Good.
Yeah.
I think it's good.
Yeah.
Nice. Okay, thank you. Finish.对，跟张连讲一下吧。
拿个干纱布。
哦。
我去。
按一会儿，因为有点像，按一会儿。